You have three organ systems that sit intimately tucked deep within your pelvic floor and core muscles: the urinary bladder, the reproductive organs, and the lower bowel. All three organ systems can have associated dysfunctional disorders that can commonly be triggers of the spasms and clenching that occurs almost universally when the body reacts to any painful stimulus or even the simple memory of previous painful stimuli in the pelvic region. Cumulative research has shown that chronic, persistent pelvic and genital pain is actually triggered by the bladder and or the lower bowel function at least 80% of the time, and by gynecologic disorders alone only about 20% of the time. Nonetheless, it is still most common for young women to seek care for these problems from their gynecologist or women's health provider. This presentation is urging you to learn and to realize that the typical treatments for chronic pelvic and sexual pain are leaning away from the traditional causes of pain limited to specific gynecologic disorders listed on the left side of your screen: endometriosis, ovarian cysts, pelvic adhesions, pelvic inflammatory disease, pelvic congestion, and severe dysmenorrhea, and towards the following list that you see on the right: gynecological triggers, urinary bladder triggers, irritable bowel triggers, hypertonic pelvic floor dysfunction or clenching of the core muscles, and neuropathic pain, meaning pain related to the central and peripheral parts of the nervous system. Consequently, many of my new patients have been told, there is nothing else in there that could hurt. Everything we have looked at is normal. I then go on to explain that there are two very important misleading and incomplete aspects of this depiction of the female pelvis, this picture that most people see on their doctor's examining room walls and in their health books since middle school. First, the uterus and ovaries seen on this picture are deceivingly pictured way up near the umbilicus or belly button. That positioning of this anatomy does not actually happen until about 15 to 16 weeks of pregnancy, and as can obviously be seen, the uterus in this picture is not pregnant. In this respect, this picture is a cartoon-type drawing that is not anatomically correct. It is simply meant to show that the three main organ systems in the pelvis are the lower urinary tract, the reproductive organs, and the lower bowel. This may not seem important, but in actuality, it is terribly misleading in many circumstances, such as when a young woman goes to her doctor or the emergency room doubled over in pain, and everyone believes it must be her ovary, or certainly a female issue, when in fact her ovaries are located considerably deeper or further down in her pelvic core than what this picture indicates. So when the ultrasound, the CT scan, or any of the other tests don't show anything abnormal, everyone is puzzled. When this happens repeatedly in young women, they begin to believe and are even told that the pain must be in their heads, that they are seeking attention, and or they are just drug seekers. The second and considerably more important reason this picture of the pelvic region is wrong or incomplete, and which begins to explain to our patients why all those tests they may have undergone did not show anything obviously serious, is that there is indeed a great deal more to the anatomy in the pelvic region that is just not shown in this picture. We then show them the rest of the story. These pictures show much more of the complete anatomy of the pelvic region. Patients are also surprised when I tell them that quite a number of years ago, when I was in medical school, I actually won the anatomy prize, and then came to realize that I never really needed to remember these muscles, nerves, and ligaments as a practicing gynecologist. What I have now learned over the past decade in specializing in chronic pelvic, genital, and sexual pain is that the actual causes of the chronic persistent pain itself are all of these neuromyofascial components, meaning nerves, muscles, and ligaments, and that the bladder, bowel, and reproductive organs are commonly acting as triggers that set off painful but protective responses in the region. Just as in any other area of the body, the muscles, nerves, and ligaments go into protective splinting or bracing mode as a result of current tissue injury, protecting against further injury and even when the system is reminded of past injury. These structures are trying to immobilize the region in order to control the pain. But contrary to putting a cast on an arm or a leg, it becomes virtually impossible to immobilize the entire pelvis, unless we would be encased in a total body cast. It is important to note at this juncture that comprehensive assessment and treatment of chronic pelvic pain therefore would naturally include specialized pelvic floor physical therapy to rehab and release long-term muscle spasming and trigger points, as well as a working knowledge of diagnosing and managing chronic nerve-type pain in the pelvic and genital region.
In this regard, there is emerging chronic pain research that is clearly showing the role of central, peripheral, and autonomic nervous systems in the perception of dysfunctional distress signals, even long after previous tissue injuries have healed. The research world is increasingly discovering the importance of retraining the brain to allow for more balanced representation of the continuing signals coming from the complex anatomy of the pelvic region to be processed in a much less threatening manner. This in turn allows for the volume dial of the nervous system to decrease significantly, and therefore dial down the pain itself. Both bottom-up and top-down approaches are required to address the many levels of pain and suffering induced over time with pelvic, genital, and sexual pain disorders.
It is also important for you to understand that the typical complex of pelvic painful problems are often associated with various combinations of these symptoms: urinary frequency and urgency, irritable bowel issues, lower abdominal bloating and pressure, vaginal itching, burning and sensitivity, vulvar pain, burning or itching, sexual pain, both entrance, during, and/or after sex, and lower back and/or lower abdominal pains.
Irritable bowel syndrome, or IBS, is the most common disorder of the lower gastrointestinal system. Symptoms include abdominal pain, cramping, bloating, gas, bowel pattern changes, and trouble with diarrhea and/or constipation. IBS may result from or cause tightening, weakening, or incoordination of the pelvic floor and abdominal wall muscles.
Digestive health and regularity can influence sexual pain because the backside of the vaginal wall and the front of the lower bowel wall are adjacent to one another, and the external openings of each are in such close proximity. Constipation puts pressure on the vaginal wall. Bowel movements that are too large or too hard can cause tears in or around the rectal opening called fissures. Loose bowels and diarrhea can cause an inflamed and sensitive rectal opening, and that area can certainly be further irritated by repetitive wiping.
The key to digestive health is the right balance of daily fiber and water. Healthy bowel movements are banana-shaped. If the stool is too big or too hard, which can cause straining and further pressure on the pelvic floor, increase your dietary fiber and your water intake. If the stool is coming out too loose, decrease your fiber intake. We have included an informational handout with the DVD on over-the-counter medications to relieve temporary symptoms, including stool softeners, glycerin suppositories, palatable fiber products, and gentle laxatives. Of course, if any of these lower bowel issues become chronic, you must check with your primary care provider. We also recommend further study and understanding of irritable bowel syndrome using resources available on the market, such as IBS for Dummies. Regarding menstrual and reproductive organ issues, endometriosis occurs when endometrial cells, normally found only on the inside of the uterus, travel backwards through the fallopian tubes, spilling into the deep internal pelvic cavity and become embedded in locations outside the uterus. Pelvic endometriosis is a common condition, but is often overdiagnosed as the primary cause of pelvic and sexual pain.
Pelvic endometriosis is most commonly a cause of cyclic monthly menstrual pain called dysmenorrhea. However, if your particular location or type of pelvic pain and/or deep sexual discomfort are intermittent and all month long, even though it may become worse leading up to the menstrual period, endometriosis is not necessarily the primary reason for your pain. This is particularly true if you can definitely tell the difference between your typical menstrual cramps and the pain for which you may have seen so many doctors or for which you have had to seek help at the emergency room. So if you have been diagnosed and treated for endometriosis and you don't begin to get significant improvement, either after medication or surgical treatment, please insist on further testing or evaluation for bladder, bowel, musculoskeletal, or nerve-related causes of your pain.
Painful bladder syndrome, also known as interstitial cystitis or IC, is a very common disorder of the bladder. It is estimated that about 1 out of every 6 reproductive age women has some degree of painful bladder syndrome. Recent evidence also has been published that for all women with a diagnosis of chronic pelvic pain, the urinary bladder is at least one of the major triggers of the pain over 80% of the time. This condition is caused by a partial loss of the protective lining of the inside of the bladder, allowing for an inflammatory reaction of the bladder wall. Ordinary urine is quite acidic, and with the protective lining diminished, the acidic nature of the urine causes an inflammatory reaction in the wall of the bladder, which in turn begins to trigger off the typical symptoms of urinary frequency, urgency, and increased pain, pressure, or discomfort anywhere in the pelvic region.
A normal, healthy bladder only has to void or urinate about 4 to 6 times in 24 hours when drinking a normal amount of fluids. When we tell this to so many of our patients with pelvic and sexual pain, we see their eyebrows raise in surprise because they can't remember when their bladder was that calm. So often, younger women are so used to these nuisance-type symptoms that they don't even realize they are not normal. They just realize that they are commonly teased about how often they are trying to find a bathroom. After all, everyone knows that at concerts in the football stadiums, the lines for the women's bathrooms is a mile long compared to the men's rooms. And you probably know female friends who have small bladders and pee a lot. However, if you find that intermittently you have flares of bladder symptoms which include frequency, urgency, and discomfort or pain, if you hold your bladder too long, you frequently find yourself having to run to the bathroom. You typically have to stop every 2 hours or more on a car trip. And if you memorize where all the bathrooms are at the mall, then you must ask yourself about this condition. Painful bladder syndrome or interstitial cystitis often begins early in the teens or 20s and commonly flares more so after childbirth, surgeries, or other traumas. Another telltale sign is that you immediately have to urinate after sex, even if you had emptied your bladder just before sexual activity.
Unfortunately, most pelvic practitioners do not mention or think about this disorder of IC when diagnosing pelvic, sexual, or genital discomfort. But as we said earlier, over 80% of the time it is associated with otherwise unexplained chronic pelvic and sexual pain. Also think of painful bladder syndrome if you have had urgency and your doctor has prescribed one of those gotta go medications for overactive bladder, and it has not worked. Overactive bladder is commonly not associated with pain or discomfort. Very importantly, if you are being diagnosed with frequent urinary tract infections or UTIs, always ask your practitioner to order a urine culture before taking any antibiotics. Cultures take 48 hours to show if there is really a bacterial infection, and instant dipsticks of your urine can look the same with IC as in a UTI.
One of the things that we always check for at the first visit with our patients is the sensitivity of the pudendal nerves on both sides. This is easily done by pressing one finger of my examining hand into the area on each side of the pelvis near the bony prominence that we all sit on. This spot is not supposed to be tender or uncomfortable. A significant portion of our new patients do have some degree of tenderness on one side or both sides, precisely where the pudendal nerve exits from its tiny canal and branches out into the entire vulvar region. The pudendal nerves on each side of the vulva innervate the entire region of the clitoris in the front to the rectal opening in the back, including the entire vaginal opening, labial lips, and the lower outer third of the vagina. This illustration indicates how all of the sensations from bladder, lower bowel, and reproductive organs go into the sacral nerves 2, 3, and 4, and how both pudendal nerves from either side actually originate from those sacral or tailbone nerve roots. Our patients then begin to understand the connection between pain and discomfort of these pelvic organs with pain and sensitivities in their vulvar, labial, vestibular, and lower vaginal locations. Consequently, we commonly find this pudendal tenderness in those patients with various combinations of diagnoses such as interstitial cystitis, irritable bowel, endometriosis, long histories of painful menstrual cycles, and pelvic floor dysfunction. At this point, our patients begin to understand that generalized vulvodynia means pain in the vulvar region is largely and commonly due to an actual peripheral neuropathy or neuralgia of the pudendal nerves themselves. It can manifest itself in many ways, including sitting pain. There are many ways in which the pudendal nerves may be traumatized, and even the condition known as biker syndrome that affects long-distance bike riders is actually pudendal neuralgia. Many years ago, this condition in women was called burning vulvar syndrome. We will then gently touch the vaginal opening with a Q-tip while showing them with a mirror that the Q-tip is causing them to feel like it is a needle or a knife or a piece of sandpaper. This demonstrates what is called vulvar vestibulitis or vestibulodynia, which is a localized version of vulvodynia and is often only a tiny little spot at the vaginal opening, sometimes no larger than my pinky finger nail. But this tiny area can be exquisitely sensitive and is by far the most common reason for entrance pain or touch in reproductive aged women. All told, it is estimated that in the United States alone, there are about 15 million women with these vulvar pain disorders. Unfortunately, most of them think they are suffering alone. We also show our patients, with a one-finger exam carefully placed into the vagina, that the pelvic floor and sidewall muscles are not only in spasm, but are very tender as well. And we call this high tone or hypertonic pelvic floor dysfunction. While examining our new patients, we also carefully push on the base of the bladder in the upper part of the vagina. And surprisingly, to many of them, they tell us that that exact tenderness on the bladder is often precisely the pain they have experienced for years with deep vaginal intercourse. This is a strong indicator for the condition called interstitial cystitis. Painful bladder syndrome is present in varying degrees in tens of millions of reproductive aged women, estimated to be 1 in 6 females. Remember, this common condition involves intermittent and variable urinary frequency, urgency, and pain, which can remain under the radar for sometimes many years. Obviously, not all of our new patients have all of these findings, but you'd be surprised as to how many actually do. As I stated earlier, vulvar vestibulitis, actually more accurately called vulvar vestibulodynia, is by far the most common reason for entrance pain or penetration pain with sex, tampons, or any object placed into the vagina in reproductive aged women.
The vaginal vestibule is the small strip of tissue or skin that is between the regular hair-bearing skin on the outer vulvar lips and the vaginal lining inside the hymeneal ring, shown here with indicating numbers.
That strip of skin is particularly filled with large amounts of small nerve endings that, when firing off, commonly causes an inflammatory reaction, leading to increasingly severe sensitivity. This sensitivity is most noticeable at the back part of the vaginal opening. That small area consequently can get red, inflamed, and so sensitive that even a Q-tip touching there can feel like a needle, sandpaper, hot poker, or other equally miserable sensations. These symptoms are often mistaken for yeast or other vaginal infections, so if you've been treated over and over for such infections and keep having this problem, please try to find a practitioner who is familiar with these disorders. Often vestibulitis is associated with other pelvic pain conditions such as painful bladder syndrome, irritable bowel syndrome, or endometriosis.
The predisposing factors for female pelvic and sexual pain include stress, anxiety and depression, genetic and hormonal influences, history of pelvic trauma or injuries, such as previous pelvic surgeries, accidental traumas, falls on the coccyx or tailbone, straddle injuries, previous or current physical, emotional, or sexual abuse, and often long-term pelvic stress or injuries from sports and other physical activities. Commonly, pelvic pain is more on one side of the body. Structurally, the body is not symmetrical, and consequently, even slight curvature of the spine, leg length difference, being left-handed or right-handed, left-footed or right-footed, all can have a bearing on long-term cumulative stress on one side of the pelvis or the other. As an example, recent information has shown that young women in sports have 7 times more ACL injuries to their knees than do young men. And if a knee is favored for a long enough period of time because of pain, the opposite pelvic and hip area take more stress and can contribute to pain on that side of the pelvis.
Many of the painful problems that we have discussed in this first part of your educational process about pelvic and sexual pain disorders are quite common and often begin early in life. Painful bladder syndromes and vulvar vestibulodynia, severely painful menses, pelvic endometriosis, irritable bowel symptoms, and other pelvic disorders often begin to become symptomatic in the teenage years and early adulthood. We believe strongly that combined with the common injuries that occur in young athletes, the stresses that have become more common in the age of technology and social media for young people, and the unfortunate prevalence of physical, emotional, and sexual abuses in our society all add up to the fact that many of these issues could and should be recognized, diagnosed, and treated so much earlier than they currently are. We hope that much of what we are trying to teach with this DVD will contribute to the overall raising of consciousness in our young people, healthcare providers, athletic trainers and coaches, parents, teachers, and anyone else who might become more comfortable with talking openly about issues of pain and sexuality. Prevention of so much secret suffering is our ultimate goal.
In this presentation, we are urging you to be proactive. Try to take care and find help for those conditions as early in your life as possible. You do not want to get here. Or, if you find you are already here, we want to help you get to a better place. Find the right practitioner using these resources that are available to you: the International Pelvic Pain Society, Interstitial Cystitis Association, the National Vulvodynia Association, the Endometriosis Association, and the Institute for Women in Pain.